Hi, this is Dr. Jennifer Clement-Gangling, and today what I'd like to talk about are acute GI disorders. This is an area that you really need to expand your differential diagnosis, and we're going to hit some of the big guns that you need to be able to recognize in your clinical practice. So as you look at this slide, you're probably like, whoa, look at all this busyness on this slide. And I want you to pay attention to that because with abdominal pain, you need to have a diverse playbook for the differential diagnosis that may come across your desk, or with the patients that you are seeing in the clinic. So when you look at this slide, I want you to think about the different areas of the abdomen and what potentially could be causing the pain. So when you think about the epigastric area, you think about peptic ulcer disease, you think about GERD, it could be referred pain from an MI. I actually had a patient years ago, and that was her chief complaint was abdominal pain. And sure enough, she had some risk factors. I did an EKG, and off to the cath lab she went. So you think about that. You could also have a duodenal ulcer, hiatal hernia in this area. Moving over to the right upper quadrant, one of the things you need to think about a lot is acute cholecystitis and maybe biliary colic. Patient also may have pain to the right upper quadrant if they have hepatitis. They may have hepatomegaly secondary to fluid congestion with CHF. It may be a herpes zoster. And the pearl there is that you need to make sure that you actually take a look at your patient's abdomen. You can't examine them with their clothes on, the gown, etc. Because I actually had a patient come in with abdominal pain, and when I looked at her abdomen, she had a huge zoster right over the dermatome that hit the right upper quadrant. So always make sure you take a look at the skin. You also may have some pain to the right upper quadrant with referred pain from a pneumonia. So those lower lobes, pneumonia sometimes can get referred into the abdomen. Moving over to the left upper quadrant, this is an area you worry about a splenic injury in your adolescents, your children. Oftentimes there can be it's a common injury, handlebar. They're on the bike, they fall on the bike, the handlebar goes into the abdomen. So you need to make sure you take a good look at the abdomen. And is there any pain? Is there any ecchymosis into that area that would make you believe there might be a splenic injury? Individuals with a gastric ulcer, gastritis may have pain there. Your patients with mono, pancreatitis, and again, referred pain from a left lower lobe pneumonia. Moving over to the right lower quadrant, we often think about appendicitis, okay? And in your childbearing females, you need to think about that ovary. Is it an ovary torsion? Is it an ectopic pregnancy? Is it a ovarian cyst? So it can complicate things a little bit, your females with right lower quadrant pain, and you need to be sure to rule out some of those diagnoses. As we know, ectopic pregnancy can kill. With your men, sometimes they can have pain to the right lower quadrant with a testicular torsion as well. Moving over to the left lower quadrant, this is an area you can think about diverticulitis. This again can be a ruptured ectopic pregnancy, an ovarian torsion, testicular torsion. It also can be a ureteral calculi, or sometimes with individuals with regional enteritis, they may have some pain to that left lower quadrant. Periumbilical pain. This is an area that a patient with appendicitis may present. The pain initially will be in the periumbilical area and it will kind of land and kind of root into that area of the McBurney's point. You may see pain to the periumbilical area with a small bowel obstruction if it's early, and with gastroenteritis. This is an area where the transverse colon lies. Now, with a patient that comes in with diffuse pain, that is something that should be a red flag to you. Does this patient have peritonitis? Is it a patient in a sickle cell crisis? Do they have gastroenteritis? Something as simple as that. Do they have a dissecting or ruptured aneurysm? Is there a bowel obstruction? And patients with diverse, generalized, kind of idiopathic belly pain, once it's ruled out, sometimes if you dig a little bit, you'll find out that this is a somatization of psychological illness, maybe previous child abuse, or a rape, something like that. So keep that in mind. So the differential for the belly pain, it's a big one. You have to be able to identify what needs to be taken care of immediately. Is this an emergency, something that needs to get referred to the ER, referred to the surgeon ASAP, or is this something that you can treat a little bit more conservatively? Referred pain. We talked a little bit about that in the previous slide, talking about how an individual with left lower lobe pneumonia or right lower lobe pneumonia may have pain to the left or right um, upper quadrants, respectively. Oftentimes, people with gallbladder disease, they will have pain to the right shoulder, or to the tip of that right scapula. Someone with pancreatitis may have pain to the left upper back. Okay, your kidney stones, that pain can move around a lot. It can start in the back, or if they have a lower obstruction, be closer to the bladder. So there, you may find some referred pain that you deal with. Referred pain, it's, a good example of that is somebody who maybe has a brain freeze, right? So you have this terrible headache because you ate something cold. And basically that's because of the nerves that are in your hard palate have become chilled per se. So keep that in mind. That's a good example of referred pain. You have seen it. Just keep it in mind. You want to, oftentimes the pain will be over the area where the problem is, but sometimes not. So just keep that in mind when you're thinking about your differential in your diagnosis. Referred pain. This is when you feel pain in one part of your body that's actually caused by pain or an injury in another part. So basically this happens because there's nerves throughout these different regions. And, for example, someone who's having a heart attack may have referred pain to the jaw, the teeth, the shoulder, sometimes the abdomen. You may have yourself had a brain freeze when you're drinking something really cold or eating ice cream. And so basically the pain stimulus is in your mouth and in your throat, but the vagus nerve is stimulated and your pain is felt in the back of your head or the front of your head. A Kerr sign. This is pain when you have pain in your shoulder blade, and this can indicate a ruptured or injured spleen. So those are some examples of referred pain. Last one is cystitis. These patients often have pain to that right shoulder or the right tip of the scapula, and that's common too. So just keep that in mind with referred pain when you are examining your patients. There are different types of abdominal pain, visceral, colicky pain, parietal, and referred. We talked about referred pain in the previous slide. So visceral pain, this is pain that originates from abdominal organs. So if you have pain to the appendix because of inflammation, you're going to have pain to the right lower quadrant. Colicky pain, this is crampy, intermittent type of pain. Sometimes it can preempt a bowel movement or urination. Parietal pain is from the irritation from the parietal peritoneum. Okay, this is sharp. This is the pain that makes it hard to breathe. This may be really, really uncomfortable for your patient. And then, like we talked about in the previous slide, referred pain is pain that's produced by a pathology or injury in one location and is felt somewhere else. So the heart, with a heart attack, you may have referred pain to the left neck, the arm, the left upper quadrant. Your history of present illness is going to be very important when you are taking a history for a patient presenting with any type of abdominal pain. You want to ask your patient, and you may use a mnemonic. I love cold spa. You may use a different one. You may use old cards, something like that. But it's important when you document that you're hitting all of these points, and this is going to help you kind of guide you with your workup. So you want to ask your patient, what is the character of the pain? Is it sharp? Is it dull? Is it worse with movement? Onset, when did it begin? The time, the day, what was the patient doing when it happened? Location, where is the pain? Does it radiate? Duration, how long does it last? Does it recur? Severity, how bad is it? You want to ask your patient to scale their pain on a 1 to 10 scale and document it as such. Pattern, are there any alleviating or aggravating factors and your associated factors? What other symptoms occur with the pain? Do they have vomiting when the pain comes? Do they pass out? Do they get diaphoretic or short of breath or feel palpitations? These are all important things to document in that history of present illness. When you're doing a physical exam in an individual that has abdominal pain, obviously you're going to look at the patient holistically. When you specifically examine the abdomen, you're going to inspect, then auscultate, then percuss and palpate, because you don't want to stir up any type of bowel gas that would mimic bowel sounds if the patient actually has a bowel obstruction. So that's why you're going to inspect, auscultate, and then do your any type of maneuvers. You're going to know any guarding or rebound tenderness in the abdomen. If the patient needs a rectal exam, then that's something else that needs to be included. And in your women of childbearing years, or with someone that you're worried about a pathology for an ovary, pelvic exam also may be warranted. There are some abdominal maneuvers that are important for you to understand, and we'll go over a few. So the Markle test. This is when you have your patient stand on their tippy toes and come down hard onto their heels, okay? You may see this being done with patients with abdominal pain. They'll ask the patient to jump up and down, especially kids with appendicitis, on the side of the bed. And if pain is elicited, the Markle sign is positive. You're looking for peritoneal irritation due to that movement. Your patient may refuse to do this, so that's positive as well. Involuntary guarding. This is when the abdominal muscles reflexively become tensed when palpated. Rebound tenderness. This is also called the Blumberg test. This is when you push down on the abdomen and the pain is worse when you release the palpating hand. So you push down, firm pressure. When you release off, the patient has pain. That's a positive Blumberg. Murphy's maneuver. Now, you may see this on your ultrasound reports, negative Murphy's sign. So this basically, if you think about when somebody's getting an ultrasound of the right upper quadrant, they're putting pretty good pressure on that right upper quadrant, and they're putting it in the right upper quadrant right under that costal border during inspiration. And basically what happens is the patient stops breathing. They just hold their breath because of the pain. Okay, that's a positive Murphy. So pain to the right upper quadrant where the patient holds their breath because the pain is so significant. Cullen sign. This is edema and blue discoloration around the umbilicus. Gray Turner sign. This is a blue discoloration on the flanks that may indicate a retroperitoneal hemorrhage. So keep those abdominal signs and maneuvers in mind when you are documenting and examining your patient. So some of the laboratory tests that you would use for abdominal pain are the following. You may get a urinalysis to see whether or not the patient has a urinary tract infection. You may get a point of care dip. You may get a culture as well. You may think about getting a CBC. Why? With a differential, because that may show whether or not this is an infectious process that is going on in the with this pain. It may also indicate whether or not the patient is anemic. So that's a couple of reasons why you might do that CBC. Your CMP, that's going to allow you to evaluate the electrolytes in your patient that's vomiting or with diarrhea. That may be very important to see what their status is, their electrolyte status is, because we know that can be problematic for your patients. You also, with the CMP, are going to look at their liver function tests, and that may also let you know, is this the liver, is this the gallbladder that's affected in the patient's diagnosis. And last but not least, the childbearing years, you need to make sure you get a pregnancy. I've worked ER many, many years, and there's been a lot of ladies who have gotten some surprises in the ER. They thought for sure they'd never get pregnant, weren't pregnant, and surprise, that is the root of all their complaints. But make sure that you do that, especially if you're going to be doing some imaging. You don't want to irradiate a little fetus. That's bad business, and you definitely don't want to miss an ectopic pregnancy, because ectopic pregnancy can kill your patient. So there are some diagnostic studies that you may use to diagnose your patients or evaluate their abdominal pain. And keep in mind, you always want to try to use the method of least radiation if you can. So that means if you can do an ultrasound first and you're going to get to your diagnosis with it, that's what you should choose. That may not always be feasible depending on the situation and your resources. So you may do a flat plate, and often we'll look at these, and this will give you an idea whether or not there's air under the diaphragm. Is there a perforation? Is there a bowel obstruction? These type of things. Sometimes with your abdominal series, you're going to get a chest, so you may even pick up on a pneumonia that the patient didn't know they had. Contrast studies. These are your barium, your upper and lower GI series. We talked about ultrasound. This is very good for often the gallbladder, for appendix, for somebody who's young or very, very thin, and your pelvic pathologies, your ovarian torsions, cysts, and even your testicular torsions. You're going to use that ultrasound. CAT scan, we do use this often. You may do a CAT scan to rule out that appendix if the ultrasound was inconclusive. Endoscopy, that's an actual visualization of the GI tract going from the top down, and then the sigmoidoscopy or colonoscopy is when they look at the lower aspect of the GI tract and are able to visualize the bowel. So let's talk a little bit about appendicitis. Appendicitis, this is peak age is usually 10 to 30. It's an acute onset, often of periumbilical pain that steadily worsens over 12 to 24 hours. The pain will localize in the McBurney's point with rebound and gartering. The patient generally doesn't want to eat, they're anorexic, and they'll have a SOS and arbitrator signs that are positive. If the appendix is ruptured, the patient is going to have a lot of garting, they'll have rebound tenderness, and their abdomen will be hard like a board, very, very uncomfortable and very, very rigid. Often the patient may present, if it's an early appendicitis, they may not have fever, but as it progresses with the trajectory, they will often present with a low-grade fever. So for your practice and for your boards, you need to be clear on what are the signs of appendicitis. So a SOS sign, that is when you have your patient supine, you're going to flex the hip about 90 degrees, and you're going to have the patient push against resistance and straighten the leg. If pain is elicited in the right lower quadrant, this can indicate appendicitis. Arbitrator sign, again, your patient is supine, you're going to internally rotate the right hip and then extend out with full range of motion, and the patient's going to have pain with movement and flexion of the hip to the right lower quadrant. Rosvig sign is when you palpate on the left lower quadrant, the patient's going to tell you they have pain in the right lower quadrant. And McBurney's point is important for you to understand, because with appendicitis, this is the area where it lies. And this is the area between the superior iliac crest and the umbilicus in the right lower quadrant. So Rosvig sign, you're going to palpate left lower quadrant, and you're going to have pain to the right lower quadrant. This graphic will show you where McBurney's point is. It is in between the right iliac crest and the umbilical region. This is what is called McBurney's point. Pain to this area may indicate appendicitis. So with appendicitis, your history, present illness, and your physical exam are going to guide your diagnosis. Like we talked earlier, low-grade fever, pain to McBurney's point, rebound, guarding, SOS or arbitrator sign, may make you suspect of appendicitis. If like we talked about earlier, you want to try to use low radiation versus high radiation. If you can do an ultrasound and get your diagnosis, that is great. But what I'd like to caution you is don't delay a surgical consult. If it looks like a duck and acts like a duck, you better get a surgeon in there to make sure it is or is not a duck. So that may be a policy at your organization too. If you're in the clinic, you may need to send your patient to the emergency room. You don't want to send them to urgent care because they're not going to be doing surgery in urgent care. So you're going to think about where you're going to refer your patient, and you don't want to miss this. Labs that you may order often will do a CBC with differential. You'll see that the white count usually range around between 10,000 and 16,000. You may see bands and a neutrophil shift that will indicate that this has been brewing for a while. That's more a severe infection. You want to rule out a pregnancy. Okay? You want to rule out a urinary tract infection. And I have had a patient that's been pregnant with appendicitis, and I have had a patient that's had appendicitis and a urinary tract infection. So, but you do want to get that pregnancy test confirmed sooner than later. So a volvulus, this is common in adults. It's caused by a bowel obstruction. It's different than an intussusception. Intussusception is when the bowel kind of folds upon itself. The volvulus is when the bowel twists around itself and kind of ties a little knot. You worry about these patients because this loop of bowel that gets wound around the other piece of bowel, you worry about necrosis because the blood flow is cut off. So these patients are going to need a prompt surgical intervention to save any type of ischemic bowel. How is your patient going to present? They're going to have abdominal pain. They're going to have nausea and vomiting, and they'll often have very green bilious emesis. They may tell you that they haven't had a BM in several days. They'll present stating that they have poor PO intake, and this patient often will have a distended tympanic abdomen. Okay, so it's important that you recognize this if this comes across your patient assignment, because this is a patient that needs prompt surgical intervention, and it won't be something that you're keeping in the clinic. They need to be referred to the emergency room to see a surgeon stat. Diverticulitis. Okay, so I want you to think about the easiest way to describe diverticulitis and diverticulosis is when you're born, it's like you have a brand new paved road, and that's the surface of your bowel. Okay, and as we know, as roads age, you may get cracks, you may get like little fissures, you may get potholes. Okay, same thing happens to your gut as you get older. You end up having a bunch of potholes. Okay, and those are diverticulum. And you usually go about your day and you're not going to have a problem. However, if fecal material gets caught in the diverticulum, this can lead to pressure, necrosis of the mucosa, infection, or inflammation. All right, who's at risk? The risk gets worse as you get older. Patients with a history of constipation with a low fiber dietary intake, patients who have a family history, patients with connective tissue disorders. And we worry about patients with diverticulitis because these patients can end up with an ileus, a small bowel obstruction, they can hemorrhage, they can perforate, they can have a fistula, get septic, then they can die. How is your patient going to present? These patients come in with fever, usually anorexia, nausea, some cramping, and usually left lower quadrant pain. Okay, they often will have acute abdomen rebound tenderness. They often will have a Rotsving sign that's positive. And just keep in mind, this is going to be pretty common. About 33% of the population will develop diverticulitis by the age of 50. So it's really important that you get a good history. Diagnosis is often made with clinical grounds. You be good to get a CBC. You're not always going to see leukocytosis with these patients, and often to get a definitive diagnosis and to make sure there isn't an abscess, you will order a CT with oral and IV contrast to take a look and see what's going on in that bowel. So the CT is the definitive scan of diagnosis. So with diverticulitis, if your patient is hematologically stable, you're going to look at those vital signs. Is there any early signs of sepsis? Are they not tachycardic? Is their pressure good? Is there no fever? Are they able to eat and drink? Are they able to move around? These might be patients that you may be able to, are they comfortable? That's the other thing too. May be able to be treated at home. However, you may have a patient that appears acutely ill. They have signs of peritonitis. They have positive Markle sign. They have a lot of rebound tenderness. They're uncomfortable. They have fever, tachycardia, low blood pressure. They may come in and they're orthostatic. These are patients that you are not going to try to treat at home, that you are not going to, treat at your clinic. They need to go to the hospital for admission. If you do treat your patient at home, you want them to rest. You want them to increase their fluid intake, and they may be on oral antibiotics. Often you will use Levaquin or Cipro twice a day with Flagyl for 7 to 14 days. Anticipatory guidance for these patients. Now, we know that constipation and stagnation of the bowel can kind of precipitate diverticulitis. So these patients, you're going to want them to make sure their fluid intake is good, that they're on a high fiber diet, and that they are, educated about the signs and symptoms of diverticulitis and when this could be a real problem for them and when they need to seek medical assistance. So imaging, if you do a plain abdominal film, you may see biliary air. In the ultrasound, this is considered accurate about 95% of the time. How are you going to manage your patient? If this is your suspect of non-acute or a non-acute infected gallbladder disease, you may do gut rest with clear liquids. You may have your patient go on a low-fat diet, and they're going to need a referral to surgery, but not necessarily that day if they're stable. They may be able to see the surgeon, and then plan to get the gallbladder out at a later date. But it's just important to find out, is your patient in trouble or not? Okay. talk a little bit about acute pancreatitis. So this patient will generally have a history of cholelithiasis, drug use, or alcohol abuse. In patients with triglycerides greater than 800, they are at risk for pancreatitis. These patients will present and often will have an acute onset of fever, nausea and vomiting, and they'll have a rapid onset of severe abdominal pain radiating to the mid-back. This is a patient that's going to have that referred pain. They may also complain of bloating. They may have guarding and tenderness over the epigastric area. These are the patients where you're going to be looking for that Cullen sign or a Great Turner sign. So the Cullen sign, edema and blue discoloration around the umbilicus. The Great Turner sign, that blue discoloration on the flanks. And that may indicate that there is a retroperitoneal hemorrhage. So these patients often, when you see them, they're going to be rocking and rolling in the bed, trying to relieve that pain, and they're generally pretty uncomfortable. Keep in mind too, if a patient's going to be admitted and they have a history of alcohol abuse or dependence, it's important that you do start the CWA evaluation with them, because the last thing you need is for this patient to seize while they're while they're admitted, and you want to be prepared for them to have the DTs or withdrawal from alcohol. So this is a population that's fairly common. With pancreatitis, the amylase is going to rise about 12 to 24 hours after the onset, and it will return back to normal in 2 to 3 days. The lipase will be elevated for several days after the attack. So you're going to definitely want to get your amylase and lipase. You're going to get a CBC. Is this patient septic? Are they anemic? You're going to look at your electrolytes and your liver enzymes. Often you're going to see the AST, the ALT, and the GDT and total bili will be elevated as well. You're probably going to do an abdominal ultrasound and or a abdominal CAT scan. These patients, they need to be treated pretty swiftly. This isn't generally, if it's an acute pancreatitis attack, something that you're going to manage outpatient. So you need to get them where they need to go for treatment. You worry about ileus with these patients, they can go into sepsis, shock, and have multi-organ failure. Another thing to keep in mind too is that patients with who are at risk for pancreatic cancer include individuals with chronic pancreatitis, tobacco use, and patients with diabetes mellitus. Peptic ulcer perforation. Okay, this patient's going to present. They're going to have a sudden onset of severe intense, probably steady epigastric pain that radiate to the sides, the back, or the right shoulder. They may tell you that they've had a past history of a burning, gnawing pain that's worse with an empty stomach. They may have epigastric tenderness, rebound tenderness. They may have abdominal rigidity. These patients, this can be a life-threatening complication of peptic ulcer disease, and it's more common with duodenal ulcers versus gastric ulcers. What are some of those predisposing factors that put the patient at risk? These are patients that have H. pylori infections, hypersecurity states, and chronic use of NSAIDs. These patients, if you're suspect of a peptic ulcer perforation, they need to be referred to surgery immediately. Small bowel obstruction. Okay. So you may have taken care of these if you've worked inpatient with the patients that end up admitted to the hospital. But if you're working in the clinic, you need to be able to recognize whether or not there's a small bowel obstruction causing your patient's discomfort. So patients will often present. They may, they'll tell you that they haven't had a bowel movement in X amount of days. When you look at the belly, they may have hyperactive, high-pitched, almost musical type bowel sounds. You may, in really thin elders with not a lot of subcutaneous fat, you may be able to actually feel a fecal mass. They may have abdominal distension. When you do the rectal exam, they may have an empty rectum. No stool is present. And so when you're thinking about this patient, the distension results in decreased absorption and increased secretions, leading to further distension in fluid, and it also can cause an electrolyte imbalance. Your patient actually may be vomiting, and they may be vomiting fecal emesis, which is, pretty upsetting for them. So what are you going to do? You're going to do your history of present illness. You're going to do your physical exam, and then you're most likely going to do a CBC. Is there an infection? Are they anemic? You're going to check their serum amylase. You're going to do a stool for occult blood, because you're going to do a rectal exam on these patients, and you're going to get your, you may even type in cross-match this patient, and then you're going to get an abdominal x-ray, okay, and you're going to see whether or not they have air fluid levels. Is there an obstruction present? This is generally something that is not going to be managed in the clinic. This is going to need to be referred to the hospital for admission. So, small bowel obstruction in a nutshell. The AAA, abdominal aortic aneurysm. So this is generally going to be a middle-aged white male with pain, tearing pain to the abdomen or in the back. It's usually a sudden onset of excruciating pain that may be felt in the chest or abdomen, may radiate to the legs and the back. Basically, a AAA is an abnormal dilation of the aortic aorta that forms an aneurysm that may rupture, and basically the patient exsanguinates into the peritoneum. So patient, you're suspect of this, they appear they may be in shock. Their vital signs may reflect impending shock, and they may have a deficit or difference in the femoral pulses. This patient, you need to be transported out of the clinic by an ambulance. They should not go by private car to the emergency department. They're going to do a CT or an MRI. They're going to check an EKG, cardiac enzymes, and this is a surgical emergency. So this patient will need to have emergent surgery. These are one of those patients that you are going to punt out of your clinic, but you're going to make sure they get there safely. No private car, 911, what's your emergency, and send them off. Okay. Ectopic pregnancy. Why is it a big deal? It's the leading cause of death in the first trimester. Who is at risk? A patient who's a smoker, history of endometriosis, a past diagnosis of ectopic pregnancy, a DES exposure, previous pelvic surgery, even a tubal ligation. Okay, I've actually had a patient or two in the past that actually had tubal ligations and had ectopic pregnancy. Patient that's doing in vitro treatments to get pregnant, patient with a history of PID. You often see ectopic pregnancy in the highest rate of the age of the highest occurrence of ectopic pregnancy is 35 to 44. Usually they'll be symptomatic around 6 to 8 weeks after their last menstrual period. These are, when you're doing your history, this is a sexually active female who has not had their period or has had light to scant bleeding. They often will have one-sided lower abdominal pain, pelvic pain, with cramping and worsening when supine or with jarring. Again, these are your patient that you do the Markle test on. The patient also may have pain that refers to the right shoulder. With these patients, you're going to want to do a good HPI, good history, social history, sexual history. You want to definitely document the last menstrual period, and you're going to do an exam, pelvic exam. What are you going to order? You're going to get a CBC. You may type in cross-match this patient. You're going to want to get a quantitative HCG, not a qualitative. Qualitative is yes or no, are they pregnant or not. Quantitative is actually the number. And why you're going to want to get that baseline quantitative HCG level is because you're going to do one at the point of care, but if the patient is hemodynamically stable and has proximate follow-up or has been seen by the GYN, they may, to rule out a ectopic, you're going to need to do a additional test in 48 to 72 hours. In a normal pregnancy, it should double. With the ectopic pregnancy, it may stay the same or actually just dip a little bit. And you're going to do that pelvic ultrasound as well. But these patients, you want to be vigilant of an ectopic pregnancy. These women can die. And you don't want that on your watch. The last topic that we're going to talk about are urinary tract infections. And so this is a common complaint that you're going to see in multiple settings. And you can see it in all different populations. These patients, they'll come in, they'll have frequency, urgency. They may tell you that they have some burning when they urinate, dysuria. They may or may not have hematuria. They may tell you they have a little suprapubic pain. They may have some lower back pain. But individuals with a UTI do not have fever, significant fever, and or significant back pain. That's when you would think about a pyelonephritis. Now, when you do the UA with a pyelo, the patient's going to have a lot of white blood cells. They're going to be positive usually for nitrates, and you're going to see maybe white blood cell casts. When you see casts in a urine, you need to think about a pyelonephritis. So the other thing that when you do your UA, if you see it comes up bacteria, large amount of epithelial cells, it may say like multibacterial, contaminants are what you need to think about. You may want to get a new sample. What is the number one cause of pathogen? E. coli. Okay, so when you look at that urine result, if you see white blood cell count, white blood cells, excuse me, you can think about inflammation. Now, this may be something you see in somebody secondary to vaginal discharge. However, if you see white blood cells as well as nitrates, you need to think maybe about a gram-negative bacteria. And when you think about a gram-negative bacteria, the number one pathogen is E. coli. It may be Klebsiella pneumoniae as well, but that's not quite as common as E. coli, and it's an enterobacteria that is gram-negative. And they're negative nitrates, think of it that way. Let's talk a little bit about some other populations. Infants and young children, if they are having a UTI, you may want to get a UTI or urinary or a renal ultrasound and ureter ultrasound just to be sure that there isn't any type of anatomical disorder. Make sure that, especially if you're sending somebody to the urologist or this is somebody that's had repeated urinary tract infections, that you want to get that culture sent out. And if you have an asymptomatic patient and the culture comes back and it's got greater than 100,000 colonies of bacteria, you want to treat that as well. Patient comes in, they tell you they have a new onset of urine dribbling, especially in your elders. You want to run a UA because that can be one of the reasons that they're having some problems with their little bit of dribbling incontinence. Pregnant women. Okay, so pregnant women, we know that we want to treat symptomatic UTIs. If it's asymptomatic bacteriuria, we want to send that off for a culture. Okay, ACOG, you can go online and see it. They have a statement about urinary tract infections and how we should treat them. And bottom line, they're saying, you want to treat when the risk is greater than the benefit. Now, we do know that UTIs can cause preterm labor, can cause miscarriage. We also do know that if we're going to treat a pregnant woman, we're going to use, cephalosporin, something like Keflex, and maybe even Augmentin to treat them. Now, there is a warning about Bactrim and macrobid. So let's just talk a little bit about that. So macrobid, and you would probably want to avoid macrobid if you can in the first trimester, and especially in the third trimester. This is important because we know that there are some individuals that have a C DP deficiency. And this, coupled with the macrobid, can cause hemolytic anemia. Okay, you're going to avoid tetracyclines. You're going to avoid aminoglycosides. This causes ototoxicity, so bad business. You don't want to prescribe that. Another option that also is in the warning page for ACOG is Bactrim, and Bactrim is secreted into the breast milk. You want to avoid it in the first trimester. Why? Bactrim interferes with the folate metabolism, and we know that we want to make sure that the pregnant women, especially in the first trimester, have adequate folate levels, because decreased folate levels is correlated with neural tube defects. After 32 weeks, you want to avoid the Bactrim too, because what happens is sulfamides displace bilirubin that's bound to serum albumin, and this can increase the unconjugated bili, and this can cause a risk for jaundice in your neonates. So just keep that in mind as well. And that's the last topic I was going to cover today. I hope we talk soon, and I hope you enjoyed the presentation.